but it is a very sensitive tool whereby it picks up many things, and at the end of it, you're not sure what is significant and what isn't. So it's a very specific test, and we don't do it for everybody. Number one, it's also more expensive, cost, and number two, because of all this sensitive information that you have, then sometimes you're not sure what exactly matters. So this is normally reserved for younger women, those below 35, who have, for example, a very high risk of getting breast cancer. And as I mentioned earlier, below 35, they are not really advised to undergo mammography, so these women would probably be needing to have MRI. Also, because the data is not enough that we have about the safety in pregnancy, it's also advisable to avoid in pregnant women. Okay. Now, another important component of arriving to a diagnosis, what I'm trying to get to is basically guide you all along this journey, as it were, on how to investigate women. Just now, so if a woman comes with a problem, how do you investigate? So just now we've touched on imaging, now we'll go into tissue diagnosis. Okay? Now, the three common ones will be fine needle aspiration cytology, punch or wedge biopsy, and core biopsy. Now, this is one of the sets I use in the clinic. Some centers, they have the pathology staff, the medical officer who does it for them, but some centers don't. So in my practice, where my clinic's in the afternoon, the doctors are free only in the morning, so I end up doing them myself. So what you need to do is, I'm afraid to touch this actually. See?
I think the printer doesn't work. Dia keluar lampu merah.
Okay.
Nampak.
Okay. I'll use my fingers then.
Yeah.
Okay, you use a green needle, a 21 gauge, and this is the syringe, right? So, because you're just using a small needle, normally it's done without local, okay? So, you use this, you take the specimen, you take a few cells, right? You prepare it on the slide, you fix it with a cell fix, and you also put some of the material in the bottle. Okay, these are the slide cases that I use. Because I tell the patients, if you need a local, it will be another injection. So it's usually quite pointless, okay? Now, another thing is a punch biopsy set. Now, if you notice, this is basically for superficial lesions on the surface. Okay, you can see, so you can use this. This is basically, this is the posterior surface of the packaging. It's a needle. It's 4 millimeter diameter. So if you can imagine, this is the handle where you hold, and at the end here, it's not very clear here, but it's like a disc. It's metal and it's very sharp. Okay? There's a shoulder here. So what happens is, because it's a bigger capacity instrument, you will need to give local. I normally give some lignocaine first. Okay? Get some standby sutures because it might bleed a little bit. So you give the local and you take the sample. So it's like a core. Okay, it's like a core device, and you tunnel your way in and get some tissue. Okay, and that goes off to the lab. Okay, and to close that opening, you might need to put 1 or 2 stitches. Okay, another way of doing the biopsy is using the true cut or core biopsy needle. This is the needle I normally use. This is fully disposable. This is a 16 gauge needle. It looks big, but it's just a needle that's big. The setup's big. Okay, you have to sort of allay the fears of the patients. So you will need local, yeah, again. Now, it's one of the things that alarms the patient's sound. Some of you may have seen this needle. It makes a funny loud clicking sound, just like a stapling paper. So normally what I do is I let the sound be heard to the patient first. I say, this is how it sounds like. So I normally take about 4 samples, okay? And this is puts a safety mechanism so that it doesn't fire on its own, but that's the needle at the end. So it cores. And this is for deeper needle, deeper lesions. Different from the core biopsy, the punch biopsy, which is superficial. This is for deeper lesions. And after you're done, you need to apply some pressure for a bit on the breast. All right. This is just to minimize the hematoma or the blood clot that could happen. So you apply at least for 1 minute, and you might need to put some steri strips, some little strips of plaster, or even a couple of stitches, depending on how much bleeding there is. Okay. So.
Doktor kata tekannya untuk pointer. Oh, okay. So kalau nak mix, doktor tekan dengan tangan.
Dengan.
Okay.
Right. Okay. Yeah.
Kalau nak exercise ni.
Okay.
Okay, Pak, macam ni. Ini tekan je dulu.
Belakang. I hope it works. Now, I have summarized on this slide the breast cancer treatment, just to make it easier for us to use it as a reference. Now, basically, the mainstay of breast cancer treatment is surgery, right? And we need to consider two different parts, which is the breast and the lymph nodes, okay? And then, so apart from surgery, which is almost always necessary, then the patient may not need chemotherapy, may not need radiotherapy, may not need endocrine or anti-hormone therapy, and the same with immunotherapy. So the rest may not be necessary, but more often than not, surgery is the mainstay of treatment. So like me? No? Okay. Right. At the time of diagnosis, what happens? More often than not, there's a panic attack. Okay? Now the panic comes from the patient, okay? Sometimes the husband as well. And then what will the patient say? They may say, take it all away, not one but both, because they go into this frenzy, you see? So your role as the managing staff would be to allay this fear, okay? Please don't panic as well, because then that will be the end of the thing. So you need to guide them. But in order to guide them, you must be fairly confident yourself, okay? So, okay, have a cup of tea or something, take a deep breath. It doesn't mean that you have to take it all away, and not only one, not both, no. Just take it one step at a time, okay? So then surgery, being the mainstay of treatment, and there's a big discussion. Is mastectomy the answer, or is breast conservation surgery the answer? This is what Professor Rosemary was saying this morning. Okay. Now, first of all, this is a very important fact that all of us should try and grasp. What's the outcome of surgery should you decide one versus the other? Now, a more recent study has found that women who undergo mastectomy, okay, they do as well as women who undergo breast conservation surgery, on condition that those who undergo breast conservation surgery must have radiotherapy, must. Okay? So what I'm trying to say is, it doesn't always mean that mastectomy gives you a better outcome. Okay? So breast conservation surgery can be as good, but you need to have radiotherapy. Very important. Okay? Now, if the woman at the onset says, I do not want radiotherapy, whatever you say, I don't want it. And then, unfortunately for her case, you cannot do breast conservation surgery. Cannot. Okay? Then in a way, she has decided for herself she wants only mastectomy. She has decided that. You didn't decide that. Okay? I shall touch a bit about breast conservation surgery. Now, what does it mean? It actually means removal of part of the breast. Okay? But your aim on the surgical side, you must get sufficient cancer-free margins. Very, very important. Cancer-free margins. And what is cancer-free margins? Many, many years ago, the doctors thought that the margin must be 10 millimeters or more. 10 millimeters is 1 centimeter, which is a huge chunk. If you have a lady with rather smallish breasts, and if you need to take a margin of 1 centimeter all around, it doesn't leave her with very much. Okay? Now, more recent data have shown us that that is not necessary. 2 millimeters is enough. 2 millimeters is small, but it must be cancer-free. Okay? That's what it is. Right? So that's breast conservation surgery. If you want to entertain or advise this diagnosis, you must be able to try and remove part of the breast, but with sufficient cancer-free margins. Okay? Now, how do you do breast conservation surgery? Now, there will be 2 types of patients. One with, more often than not, palpable lesion. So when you have a patient with palpable lesions, you normally remove during surgery. Maybe I normally use my finger to guide. So it's about, my index finger is about 1.5 centimeters. So I generally use 1 or 1.5 centimeters around the lump when I'm doing surgery. Okay? Non-palpable lesions is probably a bit more challenging and different. And not many of our patients in Malaysia come with non-palpable lesions, because most likely, maybe because we don't have a screening program. I don't know. But if you have non-palpable lesions, what do you do? Some of these women may have been found to have some abnormal lesion based on screening mammography. So what happens is, now you as a surgeon, there's nothing to feel. Where are you going to cut? You need something to guide you. So what you need to do is discuss with the patient and get your radiology colleagues to help you, is you have to have a wire put into the lump at the radiology department. Okay? So the wire will be put in through the skin under local. They'll give a local first. The radiologist will put in the wire, usually in the morning of surgery.